Welcome. My name is Joshua Levine, and this is episode 2 of the official podcast series of the Neurocritical Care Society. In this installment, Dr. Ramani Balu, Assistant Professor of Neurology at the University of Pennsylvania, interviews Dr. Andrea Morotti on an article that Dr. Morotti and colleagues published titled Lymphopenia, Infectious Complications and Outcome in Spontaneous Intracerebral Hemorrhage. This article appeared in the April 2017 issue of the journal Neurocritical Care. A link to the article can be found in this episode's show notes. Without further ado, here is Dr. Ramani Balu.
Hi, I'm Ramani Balu, Assistant Professor of Neurology at the Hospital of the University of Pennsylvania. Today, I'll be interviewing Dr. Andrea Morotti from the Department of Emergency Neurology at the Mondino National Neurological Institute in Pavia, Italy. Dr. Morotti, thank you again for joining us as the inaugural guest for the Neurocritical Care Podcast.
Well, it feels good, and thanks again for inviting me.
So I want to get right into the paper and ask you if you could tell us the original motivation for this study.
Everything started from background literature showing that a lot of stroke patients develop and acutely acquire immunodepressive state. And this is probably secondary to a disruption in the normal interplay between the central nervous system and the immune system. And so we wanted to investigate whether a low lymphocyte count leads to an increased risk of infections and then to poor outcome. And this is basically what we've done in the paper.
As someone who's attempted to conduct research using retrospective chart reviews, I can attest to the difficulty of abstracting high-quality data from medical records. Could you walk us through the methods for your study and tell us about some of the specific challenges that you faced?
The first thing to do was to have a strong methodology in mind and to establish strict criteria for the detection of secondary complications and, in particular, infections. I think this was the main challenge, but also, I think, one of the strengths of our manuscript. One of the main challenges was to be consistent with very clear criteria to diagnose secondary complications and especially pneumonia. So there's a lot of literature showing that there is great heterogeneity in how stroke physicians diagnose pneumonia in stroke patients. And therefore, we had to perform an extensive retrospective literature review to revise all the pneumonia diagnoses that were made. Now we have created quite a big data set with good quality data on secondary complications, and I hope other papers will come out of this. And it's a work that someone has to do, and I think we will all benefit from this.
So, not too many challenges. Let me ask you, were there any pleasant surprises that you had during the course of this investigation?
Well, I think one of the good surprises was that the rate of sepsis was relatively low. And so this means that we're doing a good job in preventing sepsis in RCH patients. And also one other interesting thing is the rate of multiple infections was between 6 to 7%. And I think this is not irrelevant. And we need to think that quite often patients develop multiple infections with different biological mechanisms. And these are even more complicated patients that we need to pay attention on.
So one question I had while reading your paper had to do with the selection of lymphocyte count as the independent variable. Why did your group choose this among other markers of inflammation and immunocompetence?
We focus on lymphocyte because previous studies, mainly from basic science experiments, show that lymphocytes are the cells that are more damaged by acute immunosuppression that follows brain injury. And we also looked at leukopenia, neutropenia, and monocytopenia in our paper, and there was no association between these three markers and infectious complications. And only the lymphocyte count below a critical threshold was significantly associated with increased risk of infections and poor outcomes. So we took it from basic science and we tried to apply this model to a clinical population.
Can you speculate as to why lymphopenia was specifically associated with pneumonia after intracerebral hemorrhage, as opposed to other hospital-acquired infections?
Well, it's a very good question, and I don't have a very good answer so far. But so one possibility is that urinary tract infections are also determined and mediated by other factors like local factors and the use of catheters. And other predictors of UTI may have overcome the role of lymphocytes. But again, our study is a retrospective study, and so we can only speculate on this biological mechanism.
One thing that stood out to me in your demographics table was that it seems that the lymphopenic patients, compared to those with normal lymphocyte counts, were generally sicker. They had poorer GCS scores, they were older, and so on. So was lymphopenia simply a marker of poorer health and functional reserve, or do you believe that it was an independent factor in predicting outcomes?
Yes, one may think that lymphopenia is just a marker of ICH severity, but we try to account for this, adjusting for all measures of ICH severity in multivariable regression models, and still the association remained highly significant. But of course, the perfect way to answer this question would be to have a pre-ICH lymphocyte count to see if there's an acute drop in lymphocyte count that is proportional to ICH severity. But again, with the retrospective study design, like in our case, this was not possible.
Another question I had relates to a limitation common in many critical care research papers, and that is the issue of survivorship bias. So you and your co-investigators found lymphopenia as a strong predictor of outcomes when you included only the patients who survived past 72 hours. What are your thoughts about this?
So what we think is that patients who die in the first 48 to 72 hours because of the extent of bleeding and because of hematoma expansion and acute neurological deterioration don't get a chance to develop an infectious complication. And so we don't see infections in these patients because they are no longer alive at 3 days. And previous studies show that infections really impact the outcome in the subacute phase. And so I think all our findings are consistent with a survival bias. And I think this raises another interesting point. So we may have different targets for acute ICH treatment according to time. So one target in the acute phase is the extent of bleeding and the prevention of ICH expansion. And in those patients who survive the acute phase and the risk of hematoma expansion and active bleeding, prevention of secondary complications and infections in particular may be another potential therapeutic target.
Right. I think that's definitely true. So do the results of this study change your practice in any way?
I think they don't for now. I'm not ready to give prophylactic antibiotics to all my ICH patients with lymphopenia, but I think we may increase our alertness in recognizing infectious complications. And I think prevention of complications is the mechanism by which intensive care in a stroke unit really makes a difference compared to a general neurology ward. But again, this paper is hypothesis generating, but of course a single center retrospective analysis is not enough to make any strong recommendation for clinicians and their daily activity.
Right. And so what would you like to see the next steps be?
I think the next step could be to design a randomized clinical trial to test the hypothesis that prophylactic antibiotic treatment is beneficial for patients at high risk of infectious complications, and lymphopenia may be the biological marker to identify these patients at high risk of pneumonia.
I think that's a great place to start for future work. How do you think your work might shape the methodology for future clinical research?
One relevant implication is that if clinical trials decide to reduce lymphocyte number and lymphocyte count, the price to pay is probably an increased risk of infections. And so we need to consider this when designing clinical trials, because a low lymphocyte count may lead to increased risk of pneumonia and other infections, and therefore counterbalance any possible benefit from the anti-inflammatory point of view. And the other side of the coin is maybe in the future we want to promote lymphocyte activity. In those patients with infections or at high risk of infections, somehow increasing their lymphocyte count and activity may protect them from the risk of pneumonia and other deadly infections like sepsis and other complications.
Very good. Do you have a take-home message that you would like practicing neurointensivists on the ground to get from this paper?
Yes, I think the main message is that, first of all, lymphopenia is common in ICH patients. We observe it in up to 27% of the patients. It's an inexpensive and widely available biomarker that may help clinicians to identify those patients at high risk of infections. And finally, accurate prediction of poor outcome is still an unmet need in ICH care and in stroke care in general. And maybe this simple biomarker may help clinical providers, patients, and family in understanding and predicting who's going to have a poor outcome after an acute ICH.
Yeah, I think those are all important messages. There's also literature that the systemic inflammatory response syndrome and elevated white blood cell count and neutrophil counts are associated with poor outcome in acute ischemic stroke and intracerebral hemorrhage. So maybe there's a balance to be struck between excess inflammation and immunosuppression in these conditions?
Yes, I think you're definitely right. And the association between stroke and inflammation is complex and controversial, and I think there are several players. And lymphocytes are one of the key players, but also other blood cells play an important role. And probably the interaction between different cells may explain a bit more what's going on the inflammation side in stroke patients. And this may also have implications for anti-inflammatory and neuroprotective strategies, because inflammation is a very broad term, but there are different players with very specific roles, and they should be considered when we design clinical trials targeting inflammation.
Absolutely. Dr. Morotti, thank you so much for speaking with me today and for agreeing to be the inaugural guest for the Neurocritical Care Society podcast.
Well, it's been a great pleasure, and thanks again for inviting me.
Again, that was Dr. Andrea Morotti from the Department of Emergency Neurology at the Mondino National Neurological Institute in Pavia, Italy. His paper, titled Lymphopenia, Infectious Complications, and Outcome in Spontaneous Intracerebral Hemorrhage, is available in the April 2017 issue of Neurocritical Care. I'm Ramani Balu. Thanks for listening.
This podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Follow us on Twitter @Neurocritical, on Facebook, or visit www.neurocriticalcare.org for more information about NCS and the comprehensive resources that it offers.